Okay, so today is a big day for us. With me is Dr. Prachee Sathe, who is my teacher, mentor, and she's, I would say, pioneer in intensive care in India. And actually, she was one of the few people who started critical care medicine in the country. And right now, she came here in Delhi for taking a fellowship exam in critical care of CCF. And we were discussing about the evolution of critical care for last 30 years. And I shared some of the questions which were asked by the channel members regarding critical care, that what were the prospects, how one should look into critical care as a career in future. So she was sharing the insights, and I requested her if she can share this wisdom, or she can share her insights of last 35 years to our members, and fortunately she agreed to do so. So over the next 25-30 minutes we'll have a candid sort of talk or informal sort of talk regarding critical care medicine, her experiences and her wisdom for our channel members. So if I continue to describe her in my words, I think the podcast will not finish in one day. So I'll start with a formal introduction with few of her achievements or few of her contributions in the intensive care. So those who don't know, I think most of know her by name, but she is a founder, director in the Department of Critical Care in Ruby Hall Clinic, and for the last 30 years. Yeah. She's been in Ruby Hall Clinic for the last 30 years, and she founded the Department of Critical Care Medicine. She has been mentor in various critical care institute to date, and she has there are innumerable candidates, innumerable intensivists are trained by her, who are now working well in the country and beyond the nations across various parts of the world. Then she is one of the founding members of Indian Society of Critical Care Medicine in 1993, I think, and also she is one of the founding members and the president of the College of Critical Care Medicine of CCF, Critical Care Education Foundation, which was started in 2003 or 4, I think.
It was really fortunate. Huh? Both the things were so fortunate.
Okay. And she is one of the trustee of the Art Foundation of India, which is one of the organization which is associated with developing the creativity of the children's visual art. Yes. It's one of the unique organization. Then she is also associated with the Deccan Educational Society, and she is one of the council members for it, and which take care of the education from primary to very higher level, professional level. She is also one of the member of the Zonal Transplant Coordination Committee of Pune, for that matter, region. And recently, she is also one of the members of DEI committee, which is diversity, equity, and inclusivity, which is dealing with the gender bias and other things which are associated with
equity on any platform.
Any platform in intensive care medicine. So, if I continue, then these things won't end. But so to cut short, ma'am, welcome to our channel.
Thank you.
Thank you. The ICU channel is run by the ESBICM, Educational Society of Bedside Intensive Care Medicine. Nice. And we share free education related to intensive care for the members who are who watch this or who are associated with. And we want that every little ICU, every smallest ICU, most remote part of the world should receive wisdom on training for critical care medicine free of cost. So it will it will help the students to develop their career, and also it will reflect in the patient's outcome. Anyway, so madam, now the purpose of today's discussion is that you have seen critical care from the starting, I would say, in the country for the last 33 years. And now we are going through a transformation phase, and what are the future aspects we'll discuss. So how it all started. I think you were one of the few ladies who completed MD medicine in 1987.
Yeah, that's right.
You were a physician getting into the medical field was a rare thing, and then to specialization in intensive internal medicine. So how, after passing MD medicine into 1987, how your interest developed for critical care, because there was no specialty, nobody knew that critical care existed as a branch.
Yeah, that's right. Thank you, Dr. Ankur. I think you and the newer generation who has decided to take their career path in critical care medicine, I really adore them because you have chosen a righteous path. You have chosen a good path which will help your personal development also. When I passed my MD, as you mentioned, in 1987, like anyone in that era, I was also attracted towards cardiology first.
Yes.
So I started working in cardiology ICU or CCU as we call it. And when I was working there, I started realizing that heart is not the only important organ in the body. And any organ, if it fails to a certain level, will be life-threatening. And then we have to look at the patients as a whole and not as the organ-wise system. Being a person coming from internal medicine, I always had that fascination about how human physiology works, how human pathology affects the whole human physiology, because from there onwards, I started realizing this definition of critical care. So, a patient in ICU is basically, or what is intensive care for that matter, is to bring about order in physiological chaos. So I feel if you know physiology, you can deal with critically ill patient, because then you know how to bring it up and how to support all the organs in unison so that your outcomes can be better.
But madam, when if I'm talking about 1987 or for that matter 1990, 1991, even today till date, many people didn't see critical care as a separate specialty until this COVID
Yeah,
came.
that's true.
So that time,
So it so happened that when I started working in cardiology, I gradually started realizing that this other aspect of dealing with life-threatening situations is to go into patients' pathology or pathophysiology as a whole. And so I decided not to do cardiology, but I was looking at, see, in the same unit, we would receive organophosphate poisoning patients, snake bite patients, anaphylaxis patients, because there were no other units. And then we were not equipped, we were not trained enough to deal with them. So it happened at Ruby Hall Clinic, senior Dr. K.B. Grant, who was there at that time, he himself was a cardiologist actually, but he had a lot of futuristic vision. And he realized that this is something which we can do for our patients to improve the outcomes or help the patients. It so happened that time when Dr. Margaret Branthwaite, who was a very well-known pulmonologist from Brompton Hospital, London, she was visiting Ruby Hall. And she saw what we were doing, and it was her who put this idea in my mind as well as Dr. Grant's mind, that if there is proper training, we can develop a separate intensive care unit which would be like a multidisciplinary unit and which can help any type of patient who needs support. So we started looking around, and this specialty was unknown in India at that time. There were very few people who were doing it. And one of them was Dr. Farooq Urwadia at Bridge Candy Hospital. So when I heard about it, I thought, why not go and see? And I started going to Bridge Candy Hospital as an observer. I saw very closely. And what was most appealing to me was his involvement in the patient as a whole. And then how he was dealing with his patients in the ICU. And then I realized that he was also spending time with the junior doctors, not only the doctors but even the nurses, so that the whole environment for the patient to recover could be built up very, supportingly. And in my mind, I had taken the decision that I want to do it. Now the question was where to train, because training centers in India were sparse. There hardly any.
Nobody knew critical care as a specialty.
Correct. So we started looking at UK. Now in England, this specialty was known, but it was majorly surgical intensive care. And the whole branch or the whole specialty was in the hand of anesthetists. And I was a physician. So they would not want me to come and work only in intensive care unless I was an anesthetist. So it was a very big challenge to find a right place. So again, Dr. Grant, and now his son, Dr. Parvez Grant, who also was a cardiologist and was in UK at that time. Both of them helped me a lot to find such place. And Dr. Roland Hopkinson, who was in charge of anesthesia and intensive care at East Birmingham Hospital at that time, in Birmingham.
Okay.
Now it is known as Heartland Hospital.
Okay.
He accepted me to be there. But as you would know, since I was not an anesthetist, NHS would not be able to pay me because they couldn't fit me in any role. So I was again disheartened. But as they say now, that if you have a very strong will, the doors open. Even the skies say yes. And I got a scholarship for overseas training from Royal College of Physicians, Edinburgh.
In
1990.
1990.
Yes. And I decided to spend 1 whole year only learning intensive care in UK. So I went to various places, various centers, and then with various mentors I learned intensive care. Now in those days, people would like to settle down in other countries once you have gone into a developed country. But here, me and my husband, Milind, who was highly supportive, even though he was a non-medico,
Okay.
we had decided to be in India for, the career or development. And Dr. Grant, of course, was there to tell me that you learn, come back and start the ICU. I would have been hardly 28 in my career. And it was such a great responsibility.
1990, 28 year old and going to UK and getting training and coming back. In a branch which was not known.
Not known, exactly. But none of my family members, either my parents or my in-laws or my husband, none of them said, "Ki ye kya kar rahe ho? Why are you doing that?" In fact, they encouraged. Yes, you want to do it, you do it. We will support you. And once I came back, Dr. Grant told me, okay, these 4 rooms, patient rooms, we are going to break down and we are going to convert it in ICU. Tell us the design, how you want it. And you can imagine, I was such dreamy-eyed person at 28 and I wanted to build something new. I wanted to go ahead and help the patients. I was ready to take up critical care as my full-time career. And we started. We developed. There were hardly any ventilators. There used to be birds ventilators at that time. And we didn't even have pulse oximeters. Can you believe that?
So, means my question is, the speciality was not known. No, there was non-availability of instruments or something.
Equipment nahi tha.
Thanks to Dr. Grant who asked to start a unit in
Space,
critical care.
yeah.
But how you managed? What challenges do you face then setting up a unit? It's a sort of ICU, moving out from the cardiology and setting in multidisciplinary ICU. How did you manage? What challenges do you face?
It was a great challenge, no doubt about it. And I did not have any equipment, as I told you. And that time, the technological gap between developed and developing countries was huge.
Okay.
And we couldn't afford to buy international level or international standard ventilators, paying in dollars or pounds. And it was a big challenge. So we used to use whatever those old ventilators were. Anesthetic ventilators we couldn't use in ICU, but they were birds ventilators. And then we decided to go ahead with what was called as OMEDA ventilators.
What is bird ventilator means, madam?
Bird ventilator is a small pressure cycle ventilator which would work only on high pressure gases which were attached to that. So it would work like a pressure ventilator. If you search in the on the internet, you will find, and we will give a link also. But we worked on that because at least it would save some lives, which were in reversible conditions. There were no pagers, forget about mobile phones. And it was like I was the only person who had at least gone beyond the tall wall and seen what intensive care was practiced in UK. But then I was full of enthusiasm. So I said, whoever wants to come, I will teach them. So literally hand holding, I taught nurses how to manage a patient in intensive care. Then whosoever wanted, I had one registrar coming from orthopedic background, somebody coming to me from microbiology background who wanted to work. One person came from ophthalmology, that for time being till I'm studying for that particular exam I want to work. I allowed anybody to work, but I could infuse my enthusiasm into them. And some of them actually stuck around and then they developed their further path in critical care. ऐसा भी हुआ.
Huh. I'm interrupting because when I was discussing with you on the tea, you were telling a story regarding that not only ventilator, even the pulse oximeter at that stage was one of the first few pulse oximeter you had to get it from the airport. Can you just share that?
So when our unit got ready, by that time, the pulse oximeter started being available. But the size of my ventilator was, the pulse oximeter was big, like a monitor. And we ordered 2 pulse oximeters. And as you know, it used to be so difficult to convince those octroi people and customs people. They wouldn't know what kind of machine it is. And they would cause all sorts of obstacles and paying the taxes and octroi and this and that. So I discussed with Dr. Grant, and in fact, I went to Bombay in my private car to talk to customs people, to explain to them what kind of machine and life-saving machine this is. And literally putting that in the dicky of the car, we got 2 pulse oximeters. And then we would take from patient to patient. But I thought, what a great thing we have got.
And now it is there in everybody's finger. Even non-medical persons use it.
Everybody, during COVID, everybody has a pulse oximeter at home. But when this small pulse oximeter became available, which Dr. Grant presented me at that time, and I used to feel like a queen wearing it around my neck and going around with that small pulse oximeter, like my stethoscope on one side and that pulse ox, and from bed to bed I would go. So I said, oh, I am such a fortunate person that I have got a portable pulse oximeter now. So there were, such milestones when we were developing ICU. And then I started getting dedicated doctors who wanted to work in ICU long term. So that till that time it was just, bedside training, teaching. And then it so happened that when I started ICU in 1991, there wasn't any other multidisciplinary unit, like surgically also they will take care of patient or bedside dialysis. And we could develop that.
So just want to ask, madam, that you started with this new fancy term of multidisciplinary ICU for that matter. You got nurses trained and you get registrars because nobody wanted to work in the ICU for that matter. It was
lifelong or longer time.
It was something a part-time sort of thing. Now my one query, if you don't mind, even today, at certain places, or you would say after COVID, this era, time has changed that people are recognizing intensive care as a specialty. So what was the acceptance among other consultants that this is ICU which your patient require? We are putting on the ventilator, we are putting on the vasopressors, we are putting lines, central lines. Was there a challenge or something you faced?
Yeah, very, very big challenge actually. The people, even the senior consultants from various specialities, would not look at ICU very favorably. Some of them would, but some of them would not. And they would say, why are you putting every patient on ventilator? Or every patient who is going to die should go to ICU, that's all.
That's what.
So that kind of outlook was there. But when they started seeing that this can really be life-saving, means we all know that ventilator is not a lifesaver from that point of view, but we can buy time by putting a patient on ventilator till the time the patient's pathology reverses and patient becomes all right to take his own care. So this is like a bridging the gap. But if we do it right, it helps. So gradually people started realizing it and the consultants started accepting it.
So at that time, as you said, there was no pager or no WhatsApp, or even we have also faced that era. There was no WhatsApp, or we found it very difficult. Now it is very easy to communicate. That there's an X-ray.
So it used to be like that, that by the time I would finish work in the ICU and reach home, landline would have had given a message to my family members, okay, वापस बुलाया है, you are called back again, and I would come back because there was no other go, and I would feel that I have got 4 patients on ventilator. I am breathing for them. It is as good as, I have got responsibility to look after their breathing. So if something is going wrong, I must go and see. For that matter, if at all, me and my colleagues, we wanted to go and watch a movie, we had to give our phone number I mean that cinema hall's number to our telephone operator of the hospital, that in case of emergency you call. And sometimes, there would be flashes that one of our colleagues is required back in the ICU.
In the cinema?
In the cinema hall.
Cinema hall.
Yes.
It
used to be really funny. Or if we family members go out for a movie or late night show, then before going home, I would ask my husband that please allow me some time. I would drop in the ICU and then we will go home. And he would also support that.
I remember that one of the stories which is very popular, that you were sick at that one particular point of time, and the ICU called you, and you always said that ICU is your first baby. So you called the ambulance, or for that matter, I remember there's a car.
No. There was a vehicle from the hospital which I asked for, and I literally was lying down on the back bench of the car, back seat
And
of the
you
car.
went back.
And I felt that patient is far more sick than me. So I need to go, because if I have taken the responsibility of the patient, I must do justice to that. So the involvement in the patient and the passion in your work, that is what actually makes an intensivist click and be job satisfied. I think the most important thing which we get in intensive care is the job satisfaction.
We see a patient as a whole, and once patient is saved, we feel so relaxed. Even after lots of burnout, we'll discuss that.
Yeah. That's right. But patient, to watch the patient getting better is additional boon. But the job satisfaction is that whatever science you have been able to apply it bedside to the patient to help as much as you can, because there are limitations to medicine, we know.
Those one important story to share, that in the ICU nowadays the nurses fill up the ICU charts and all of that. Madam was one of the few people who designed the ICU chart, that hourly urine output should be maintained, hourly pulse.
There were a lot of things, yes. And then we used to have the small charts, so you have to keep on flipping, and you cannot have really at one go see everything. So there has to be a daily chart. That is what I used to feel. And then that became huge. And now we know it has become a part of it.
ICU chart.
Many people have contributed in that. I wouldn't say it was only my
But that was one of the challenges, I would say.
So when I introduced it in our hospital, people would feel, afraid of ye kya hai? Or some senior doctors would come and, throw it away. Ye kya? What is this fancy thing? Old charts are good. So challenges were faced at every stage, because people don't want to accept the change. People who have already reached certain level in their career. But the juniors, the nurses started gradually accepting it. Now though we are going towards EMR. But before that, for a large number of years in various ICUs, and even now we are using the papers to write it, the charting. And that itself is a great learning for the junior doctors. You know what? I tell my junior doctors that when you join here as a resident, you must spend a few days with the nurses to see how they are monitoring and how they are looking after the patients. Because they are there every moment. Far more time they spend bedside with the patients than the doctors. And we get to learn a lot from them.
And this is a very good tip, and it means new joinees who are coming to ICUs, give them 1 or 2 weeks times to spend times with the nurses rather than the residents. So they understand how they are taking care of the patient. Very nice, madam. Now, so we got to know you get into the critical care. Then you established a unit in the Ruby Hall, and there was challenges. And now, it was somewhere around 1993, then few people, you were one of them, and they have a division.
Actually, when we established ICU in Pune, I wanted more and more doctors to get involved. So we had started one intensive care group.
Okay.
And every month we used to have informal meetings to discuss the patients and the management of ICU patients.
Okay.
Many doctors in Pune were involved in that. Senior doctors were involved in that. So when I realized that some like-minded people in Mumbai also wanted to come together, I was also invited there. And then we all thought that we should have an Indian society of critical care medicine.
So that's how it was
And
formed.
that's how it was formed. So we did not insist that since we have started the first group, we should be taking the credit of that. But we became a part of the national movement.
So you were one of the
to
few
develop.
people who started and formed this
Yes.
Indian Society of Critical
Yes.
Care Medicine in 1993.
Yes.
So choosing a branch which was not known to anyone, getting trained
Yes.
outside the country,
Yeah.
coming back, establishing a unit, facing overcoming the hurdles, then forming a formal group of training, and then taking this to a national level and forming Indian Society of Critical Care Medicine. Amazing, man.
I really feel very happy looking
So,
back.
means forming in 1993 a society with a vision that this specialty is going to be very important in future. That was itself is a great vision.
Actually, because at that time, the word intensivist was not known.
Not
if
today,
somebody
also-
asked, if somebody asked, what are you doing? What is your specialty? And if I say intensivist, I say, "वो क्या होता है? What is that?" So, but I had read a story about one intensivist in the US who said that I'm very happy that now my mother understands what intensivist is. So it is not only in here, but even abroad. It is so.
Thanks to I don't know, I mean, thanks to COVID or not COVID, that this
Yeah.
specialty has got recognition recently worldwide.
Worldwide.
And madam, now you have formed the society. We are somewhere around 1993, and you came up with a training course also. You took. I think you were one of the few people who started training in CRRT,
Yes.
and I would say.
Yeah, that was in 1996 or 97 that we had conducted the first workshop of CRRT by inviting some specialists over from Australia.
Okay.
So that was the time. Not only that, since you are asking about the first few things which we could do, one of the things which I will never forget, and it really gives me goosebumps to remember that was in 1997. That time, 1996, I think, was Human Organ Transplant Act was passed in India.
Acha.
Or 93, I don't remember exactly, but 2-3 years before that. And then one cadaver organ donation had taken place in Mumbai, and within a month, it was us at Ruby Hall in our ICU. I was the first intensivist to motivate the family of a brain dead patient to donate kidneys.
Okay, 1996,
97.
97.
That was the first cadaver organ transplant in the rest of the Maharashtra.
Did you face any problem in that? Because right now also people have a challenge that my patient is alive and taking a dog. 97, nobody heard that this is a category.
Nobody knew that. And, myself, then our nephrologist, our social worker, we all were in hospital the whole night. And we were trying to convince people. Some of the family members had got convinced because they knew what was it like, what life was like with continuous dialysis requirement. But the police didn't understand because they knew the law, but they didn't understand. Luckily enough, but police we have to get involved now because we have to avoid post-mortem. We have to inform police that this is what we are doing, which is a normal procedure even now today. So one of the police inspector's wife was a CKD patient. And he understood what it is, and the law has been passed, and now it is allowed legally in India. And then gradually the acceptance came around, and that patient who received the kidney is still alive. You know that?
Right now?
Yes.
Almost 30 years
What is
later?
it?
Oh, wow, amazing.
So that was really, it gives me goosebumps that otherwise, if they would not have understood, literally, we had to go back to, behind the bars. Because people wouldn't understand, Now it has become such a commonplace. But the convincing part of it is so painful, so difficult, and still requires so much of empathy. That challenge remains even till today.
Yeah, it's a very sensitive
Very
issue.
sensitive issue.
Now, regarding this sensitive issue, one more thing in my mind, which I knew, because we are discussing in an informal manner. So, somewhere around 1999, I think you got your second baby. I saw first baby. You always say that is an ICU is your first baby, and then at this stage you had your first child.
See, what happens is when a woman gets into a full-time career, it is really very difficult to have a balance between the family life and work life, you know. And somehow I was very career oriented, and luckily both my families and my husband were very much supportive. So I could go ahead. But at the same time, I did not want to do injustice towards family also. So I was thinking that once the ICU is established a bit, then we will go ahead family way. But as a woman in this field for last 8 to 10 years, like I think 6-7 years,
6-7 years,
I faced a lot of problems, and people would look at, I was such a small person, small frame person at that time. People wouldn't take me seriously. Sab kaam karne ke baad people would say, nahi, please call a big doctor. But that, I think everyone of us goes through that. But I could see that the way the society looked at women, the way the hospital management or senior doctors looked at the women, it was different in the sense, if there was a man in my position, it would have been a different life, different progression of career. So that seed always remained in my mind. Anyway, whatever it is. So in 1999, my son was born, and I'm really happy that my husband was totally with me to go back to my career after a few months he was born. And my family, my mother-in-law, my mother, everybody came forward to support him. And he, when grew up, he also understood the importance of the kind of career or profession which I was doing.
The kid also, the kid.
Yes. So he also would support, he also would, accept if I had to go odd times or leaving a story halfway and go to see a serious patient sometime.
No, we have listened those things that sir used to carry the baby in conferences also. You are taking a lecture session in the conference, and
he would look after the baby. Yes.
Like that.
But if a woman has to be a real professional without asking any concessions, then the family has to support a woman as much as a woman supports the spouse or a woman supports the rest of the family. So it has to be mutual. So ultimately, these are the human values, when mutual respect is important for anybody to develop as a person or personal growth.
Very, very nice, madam. So, madam, I think after delivery in the 3rd and 4th month, she resumed the work back.
At least part-time, I resumed.
Resumed the work.
Yes.
So, you now you formed the society, had the kids, resumed the care, and meanwhile, you also had trained for CRRT, ECMO for that matter also was.
We had started looking at ECMO because Ruby Hall was a very active center for cardiac surgery. So, all open heart surgeries, cardiac bypass pump, and the know-how was there. So we decided to use it even for ICU patients or respiratory failures, where we wanted to bridge the gap. And with the support of cardiac surgical department especially, we did go ahead, and the ECMO Society of India, people from ECMO Society of India also helped us a lot initially to establish this therapy.
And what you were training in workshops, then you converted it in a formal training in the source of IDCCM, Indian Diploma in Critical Care. And
that was under ISCCM. Lot of intensivists came forward, everybody contributed, and these courses were started. And really, my joy wouldn't, only sky was the limit, I would say. Because formal training to be given to Indian doctors to have a dedicated career in critical care was one of the dream for all of us.
All of us.
Yes.
Till today also, everybody wants to get trained with the proper course structure.
And we had decided that we will not have any limitations. So people from either anesthesia background or pulmonology background or internal medicine background could come into this specialty. So it is a multidisciplinary from that point of view also, that people from multidisciplinary backgrounds can come and develop the career path. At the same time, it is multidisciplinary from the point of view of patients also, because any system fails would get supported in the ICU.
Yes, so when I am discussing this training programs, madam, one more landmark year was somewhere around 2003 or 4 when you started in joint as a joint venture, or you would
Yeah.
like-minded people again came and started Critical Care Education Foundation?
Yes.
I think
That's right. So we were developing it in India. We were trying to have bridges to international societies also, or we wanted to increase the standard and exposure of Indian doctors. And so it was with the like-minded people, it was decided to make bridges to Australia and New Zealand.
It was one of
and
the
six
countries having good
advanced critical care. And that is where I got associated with Critical Care Education Foundation. We went to Australia, we saw how the training is given, how the exams are conducted, and I helped in developing those courses in India under CCEF.
So then they people come out with the course FCCM, or Fellow of the College of Critical Care Madams.
Yes.
So this was an Australian pattern exam, which madam, what I have listened from Dr. P.K. Jain, who I think one of the members in the founding president of ICCM, and he also founded CCF also. Along with you, you were the president of College of Critical Care for almost more than 10 years.
Right.
And so they said that they brought out the Australian examiners also.
Yeah, so with the help of Australian faculty, in fact, we developed this, and every year for the conference as well as for conducting the exam, they used to make a yearly visit to India.
So they used to come here.
They used to come over here. They used to be part of a faculty for the yearly conference. They used to be part of faculty as examiners. And only when they got convinced that it is running pretty well, then they stopped coming over here by handing over everything to CCEF.
Means now the standards are matching and it can be self-sustainable. Amazing. Not knowing anything about critical care, a country which is not knowing anything, and up to a standard where the foreigners, where the advanced critical care countries are coming and saying, no, your standard is matching ours, and now this can be...
In fact, some of the students who completed this examination and training under CCEF could have accelerated pathway when they went to Australia also.
Okay.
They could get into the system there.
And the training still continues, and now, madam, you are training the transplant teams in D.Y. Patil or some other institute?
Yes, I am really happy to be associated with the medical college, and D.Y. Patil is the medical college, one and the only, which is actually developing the transplant program. So again, the critical care department comes very much in picture before the transplant and for post-transplant care as well. So to mentor this team, I am helping, and I really feel proud that they have done like 20 thoracic organ transplants also.
And the team is involved, the critical care team is involved very closely with you.
Yes.
And I want to share one story. I want to listen from madam that in when COVID struck, in 2019, early 19 or 20s, then there was shortage of ventilators, I think.
Yes.
And I think the government has invited people to develop
indigenous technology. See, I always thought, Ankur, that the technological gap was there. As I mentioned, it was like 10 years technological gap. If something new comes in developed countries, for us to receive it, 10 years would pass. And not only that, if we buy equipment or technology in international market, we're paying dollars and pounds, and ultimately to recover those, we charge our own patients. We means the hospitals who are running this. And so it becomes, as per our GDP or our income levels, that becomes too much. And that is how intensive care becomes more and more expensive. And that is how it starts, not offering enough care for people who come from low socioeconomic strata, or even for that matter, medium class or middle class people. And so this was an opportunity. See, as doctors and as ICU specialists, we all were so overworked at that time. And many people, especially the vehicle production units, thought that they could develop ventilators. So many people came to ask us about the help or whatever they had developed, they wanted us to try. But they were very, very primitive things, So that could not really get established for bedside use. But we had developed one video to explain the basics of technology behind the ventilator.
How it works.
To the people who really wanted to put in their efforts and develop it. And there was a group from IIT Kanpur of young enthusiastic graduates who had their own startup, and they wanted to develop oxygen concentrator and a ventilator for ICU. And whatever small thing they have started with, they wanted us to validate it and guide them further. And throughout first 1.5 years of COVID, we worked on that. And we did proper validation for almost 1 month. And then 500 ventilators, which were manufactured by them, went to various centers all over India.
Country-made.
Indigenous ventilators technology.
So you can imagine bringing the pulse, this much huge pulse oximeter from the customs, from the airport, in the car to the hospital, and now getting and being a part of developing indigenous ventilator of the country during a time where pandemic struck. So this shows the dedication of Madam, how she loves critical care.
I love critical care, and I always want to try new things. Somehow that is my nature, to take the new challenge. If somebody asks now, even at this age, when I thought that I should start winding down a little bit, but it never happens because something new comes up, and it's my nature to take the challenge and to develop something new. So I'm really so happy that that ventilator during COVID, which was developed, was not top of the range, but then they have come up further, and they have even gone one step ahead of international standard ventilators to even include carbon dioxide monitoring and colorimetry also in the ventilator, in the same ventilator. So it is really excellent to be a part of an indigenous effort to develop some technology which is going to be useful for the masses. But I told them that the cost of the ventilator has to be much less as compared to the international market.
They somehow managed it.
They somehow managed it.
So you see, even if I see for NMC or the national medical body, to recognize intensive care as a formal training program, they included
it was much later.
This 4, 5, 6 years back that they included
BNB, but FNB in critical care was, I think, 10 years, more than 10 years back.
But it was too late. And Madam started way back with the vision, and now
we all at ICU, because it was our generation, those who were involved in founding both these organizations.
And now this intensive care is coming through formal national training programs in various institutions. So now when we discuss of these training programs, Madam, many of the members which are listening right now, some of them are working in the intensive care unit, some are aspiring intensivists, some look critical care as a fascinating branch where you deal with the life-threatening condition and patient recovers. So before they jump into this critical care medicine and they pursue this as a career, what things one should know, that the plus and minus of this particular field?
See, again, the medical students, graduates, or even postgraduates, when they come to meet me with their dreamy eyes that, Madam, I want to work in ICU, I ask them, what do you want to know? What do you want to learn? No, I want to learn central line. I want to put a patient on ventilator. I want to know how the ventilator works. So they're technology driven, and it becomes fascinating to use some high-end machines, But then I tell them that is not the crux of the matter, or that is not the gist of what intensive care is. But when you come in the ICU, you should be able to see that patient on the bed, it could be my brother. If my mother was on that bed, how I want ICU to run, what kind of responsibility I will take. If I am on that bed, how I want ICU to run. So if you have got that kind of empathy, that kind of passion, and you also at the same time have to have curiosity. Like how small children have the curiosity, that is how they learn about the world. On their own steam, they start exploring the world. Similarly, anybody, a new entrant in the ICU, should have curiosity. What is happening with my patient? Why this patient is in ICU? And how I can help this patient? How I can correct this physiological chaos that is happening in his body? So if this type of points of view you can instill or cultivate in your own mind, then you can be a good intensivist. Just by learning to put in central lines is of no use. But how to use it, how to apply the science which you learn to a living human being, that is what is more important.
And as you said that ICU seems very fascinating from outside, but once they get into it, they understand after a few months that it's a very demanding job. So this thing, everybody should understand that though it's a very fascinating world where you can save the life of the patients, but at the same time you need a dedication, empathy, curiosity, learning attitude. These all things should be there.
Absolutely.
Every branch has a plus and minus.
And medicine is a field which is changing very fast. Say like few years ago, if I was doing certain way of treatment for a patient, after some few years, the evidence has changed, and the way I treat, the way I give fluids, or the way I treat sepsis changes completely. So we have to be open to learn the newly expanding science and keep ourselves abreast. And that is one of the advantages. It is my selfishness to be with the younger generation, because I can learn from them, and that is how I like to be with the younger generation. And of course, it is so fascinating and so satisfying to see the junior doctors coming up, opting for this as a career path, trying to be good, complete doctors and be good human beings. So I definitely encourage all of you to walk on this path with all this background in your mind.
So to those who joins newly, when I was also getting trained in the intensive care, I get a glimpse, or I would say a little chance to visit Madam's ICU or witness Madam as a faculty, and she gave me few rules which I still follow. I think these are the four sentences I think everybody should understand. So whenever you are in the ICU, you are standing at the bedside of the patient, the first rule which Madam told that you should ask a question that why this patient is in ICU. It's very, very important. Like a liver failure patients come. Not every liver failure comes into the ICU. Fulminant liver failure comes to every
for that matter, take it trauma patient. Every roadside trauma is not requiring ICU. So why this patient is in ICU? If you start looking at it from that point of view, you know what to look for, what complications can occur, and what to monitor.
And second rule is you need to inquire that what has happened with my patient in the last 24 hours.
Right.
What is there what investigations, what treatment plan has changed, what consultations has been done. Thirdly, whether your patient...
giving over and taking over is not just a mechanical thing, You really have to understand what was happening, what has happened in last 24 hours, including the communications with the family or communications with other consultants. And 24/7 the patient is there. So even though we are changing our shifts, there has to be continuity of care. So that is very important. So I always tell that if the patient comes in the ICU after spending a week in the ward, patient has to have continuity. So you again have to take the whole history, and maybe you will click on some point which others were ignorant or they couldn't find it, and that is what probably leads you to the best of the diagnosis.
Yes.
So taking history also is equally important.
Okay, so getting to know what has happened with the patient, especially in the last 24 hours. The third point is, as a whole, overall the patient is improving or deteriorating. This also you should understand that whether what we are doing or what is going on with the patient, whether the overall patient is improving or deteriorating. And the fourth is
because that helps to communicate with the family also. You should always look at the bigger picture. We know that anything unexpected can happen, not in 24 hours, within an hour also. But if we know the overall trajectory of the disease which the patient is facing, then our communication with the family is much broader. And they also understand the various possibilities, so that they are not taken aback if something untoward happens and then they don't come to beat the ICU doctor. So we also have to learn a good communication skill based on the science behind it.
And the fourth point important is you should have a proper plan and a targeted plan related to goals for the next 24 hours.
Correct.
What are your targets?
Correct. So these are the things every round, every day we should follow and give over to the next doctor on duty.
And madam, one challenge which I face or many of the intensivists face, that the new trainees or the new doctors which are coming, they are not comfortable in doing shift rotations in the early part of the days. But we feel that it is very, very important. Can you give a small tip?
See, in intensivist's career, if you want to get into, you have to be ready to go in the shifts, because it is a 24/7 job, no doubt about it. Of course, you or us, those who are working in intensive care, also have to learn to keep our work-life balance, no doubt about that. And our own health. If we are doctors and we are looking after other people's health, it is our prime duty to look after our own health in the form of nutrition, proper rest, and exercise for that matter. And keep our minds equanimity, because
very important.
Keeping yourself cool helps you to make right decisions, helps you not to take the stress home, but look at it from a distant point of view, or with mindfulness as they call it. And that is what will help to prevent burnouts.
And madam, because we have talked about mindfulness, a few minutes of yours on the vision of, because intensive care, as madam told, and we all know, it's a very challenging field, and especially for the females who gets recruited to the intensive care, they have their own sets of responsibilities which they have to bear. So means
I'll tell you what, a woman has to be doubly good to be equal. That is what I always say, and I like this sentence, because she has to prove two different roles only she has to play.
Because there is a hesitation of taking a female residents or female intensivist in the unit, both from hospital point of view and from the team point of view.
Exactly.
So can you give a few?
So see, this is what I have faced myself. And when I have started becoming a mentor for my juniors, I have seen what kind of problems the lady doctors have to go through who want to work in intensive care. I'll tell you what, it was a funny incident when I went for one conference of critical care, and I met a lot of my juniors or students who now had established their own units, and we were all together having a get-together. And I asked them that, what are the number of, lady intensivists working in their units? And they start looking at each other's faces. And then they said, madam, this, that, then they want to go on leave, this, that. Oh my God, I was shaken. I said, you worked in our unit where we treated males and females on equal footage. Anybody who is coming from a remote village, from Saurashtra or Rajasthan or anywhere in Maharashtra, we literally did hand-holding. Everybody has developed good careers. And when it comes to you, you are giving me this kind of point of view. How can it be? And then it was a great thing happened in ICM as well, that after completing 25 years, the first woman president came. Who could think of this? Who could develop this idea further. And then at ICCM we developed a committee which is called as DEI, diversity, equity and inclusion. So anybody, any professional who wants to walk on the path of critical care should be helped to develop his or her full potential, and that is what we should do. So it is one of the topics which is very close to my heart. Not only because I'm a woman, there are a lot of men mentors also who understand this aspect, and we had male members also. And this was not only gender based, this was urban rural divide also, or people who are in various organizations and who get marginalized. So these things should not happen. So we are going to try on this, and this will continue further.
You're taking forward. So there is a one talk of Madam which I heard. I will give the link of that talk in the description of this video, where you can listen in detail about this topic. Hopefully you will find it well. Now, Madam, coming to one question which is asked very much on the channel regarding that, because the amount of effort which we put in intensive care, the money or the fee or the remuneration which we got is not proportionate. So how to deal with that?
Right. So I think in the medical field, we work passionately, but it may not happen that every branch gets equally remunerated. It may not happen. Intensive care now has come of age where people have started understanding the importance, but sometimes looking at the bills of the patient who are in ICU, my heart breaks that how can I tell them that you continue the treatment, even though I'm working in a corporate hospital or charity hospital, wherever it is, And then whatever we earn as doctors is definitely never a bad zone of income as far as the whole society is concerned. And sometimes it so happens that you have really fought tooth and nail to save somebody's life, and ultimately that patient can't pay the bill. But then whatever effort you have put in doesn't go unrecognized. You get some from somewhere else and you are taken care of. Money is ultimately the means to live good life. Money is not the goal. And that is what we should remember. But what is important is the management of corporate hospitals also has to understand this. That even though intensive care is a good source for them to earn finances, at the same time, it is a very important avenue to make that hospital robust. Because surgeons can do high-risk surgeries.
Because we have seen that because intensive care branch is always felt as a dependent branch, supportive, it's working from the bedside. So at times the hospital doesn't recognize as they say that you are not admitting the patient, it's not you are not revenue generator. So there may be a discrimination, but in the end, if the ICU is very strong or intensive care is strong,
it is a backbone. It is a backbone of the hospital. Like during COVID again, same thing, that everybody realized how important are ICUs. But even otherwise, people would come to ICU with, say, ruptured organ in the abdomen, in very critical, in very critical condition. So a surgeon can operate only if the patient can be stabilized. And that is where the role of intensive care is. And I think everybody has to work together because each one has a different role
to play
in the good outcome of the patient.
So don't get demoralized with the amount of remuneration, and don't go demoralized by the if it is called as supporting branch, because as madam said, if you do good with something, even though the something good is not coming from there, but it will definitely come from somewhere where it will take care of this.
That's right. And also, as an intensive care person, as a physician, I started feeling that we can prevent people from going to ICU. And much at a later stage in my career, I started doing OPD. And where I started making people aware and giving them, spreading the medical knowledge. Or after coming out of ICU, I started treating them. And I think that part also is important because it gives us the other end of the spectrum, other than intensive care. So it doesn't make us bias while working
Prevention
in ICU.
and then completing the whole scenario.
Whole scenario.
This is also considered.
Yes.
So now, madam, if I ask you to give some message to our audience as a mentor, as a teacher, or a person who has started, pioneered in critical care, going through this indigenous technology also development and seeing the future of it's going to be a very booming branch.
See, the future for intensive care is really bright. But at the same time, our population is now aging. When we started, the population in intensive care also, we used to get a lot of young patients. Now we see a lot of geriatric patients. And it is a demographic which is changing. And so our lookout also has to be different. It is not that, we just don't have to delay the death. We have to give meaningful life to a patient. We have to be a part and parcel of the journey where we can help the patient to become active part of the society again. And we have to learn to keep balance, and not only that, we also have to take the society along with it. So palliative care or end of life decisions, we will have to make our say in this and help the society to work together towards making the end of life satisfactory.
And end of life and palliative doesn't mean that the patient needs to be neglected.
Not at all.
But in fact, the patient needs to have
we have to honor that
and more
state.
care to that patient, because we need to make the journey as comfortable as we can.
And ultimately, all of us have to face it sometime in life. So we have to think, and that is why you were asking me about the message, parting message you were saying. So I feel if you have chosen the path of critical care as your career path, you have done a great job. You have done a great thing for yourself. But you have to have your human qualities, your scientific brain, and your physical resilience, all three of it together to be a good intensivist. At the same time, be compassionate to yourself also. You also have to enjoy your own life. You also have to enjoy your personal growth, because you ultimately want to be not only a professional, hardcore professional, but a good human being also. And that is what is our ultimate goal when we are born in this human life.
One point I would like to add in this also, madam, as you said that keeping a healthy environment in your ICU, professional ICU is also very
important. Very important. Because we are always, in an environment which is tense. There is a lot of stress. But I always say that we, all the colleagues, have to work as a team. Even senior consultants also have to be a team, supportive to each other. It becomes really like a family. And I always tell my juniors that ICU should be a happy place to work. So we have to look at life from different angles. We have to enjoy our work. We have to we should go and do outings also. Why not? We cannot go all of us together, but at least partly we can go. We should interact in different manners. And we should enjoy being a fruitful family members together working in the ICU as a team.
So nice, madam. So
there's one more parting thing, if I can tell you. That a lot of people say that there happens burnout. But luckily, for last 30 years, I have not experienced that. I have experienced stressful moments, no doubt about it. We can talk about it some other time. But at the same time, I still enjoy it. And that is mainly because of the balance of all these things, the balance of support from the family, from the society, from the friends also, and the colleagues, professional colleagues, and the working environment in the institution where I work. I would say that I am a woman. I have family. I have been a full-time intensivist. All of it I have done with free will, not because there was pressure. And if it comes to that, I have enjoyed this life so much that I'm really ready to do it all over again.
If you're given a chance that you will again start from the same.
Yes.
So nice. So the idea is love what you do. If you've chosen intensive care, love it. And once you love the field, the profession, the branch, burnout will not take place. And take care of your team, take care of your patients, be curious. And the whole point of this discussion is don't have negative thoughts if something technology or some facility is not available at your unit, where some are working the rural and the urban. Whatever resources are there, whatever type of trainees you have, whatever type of manpower or management you have, you can play a role and be the pivot. You can play a pivotal role to utilize them to the fullest.
See, I feel that the role has been given to us by the Almighty. We are only playing the role, but we have to play that role with full involvement. Whatever is going to happen will happen, but we will have satisfaction of having done the best we can.
So, thank you, madam. Critical care branch is something which is now recognized as a specialty, and thanks to you and people like you, you have that vision at that stage of time when nobody knew even the term ICU, and now the journey we have seen in the last 30 years, and it's going to be way far more fascinating in the future. So with that, thank you, madam, once again for
Thank
sparing
you,
your
Dr.
time.
Ankur, and I wish all the best to the viewers of your channel.
Thank
so
you.
much.
If you have any comments or any queries, anything you want to ask, you can ask at the comment section of the video. We'll love to reply to them. Thanks again, madam. Thank you once again. Thank you for sparing time. Thank you.